A survivor story is meant to inspire us. We learn of their tragedy, self-doubt, and eventual triumph. But what about the story of an individual who has survived by cheating death 3 times? Well, RJ Windham is that person. His story is not only motivational, it is inspirational. Through the Patient to Patient podcast, you will be captivated and taken on a real survival adventure, meeting global experts and cancer survivors just like you, where no topic is out of bounds. Now, your host, RJ Windham.
Welcome to Season 1, Episode 1 of the Patient to Patient podcast. I'm your host, RJ Windham, and for today's adventure, you and I are going to travel to the continent of Africa and meet a good friend, Dr. 𝐦𝐨𝐬𝐵𝐞. Well, the clock's ticking, so we better get going. So let's fire up the virtual rocket and head to Africa. All right. Well, Dr. 𝐦𝐨𝐬𝐵𝐞, welcome to the Patient to Patient podcast.
Hi, RJ. Thank you for inviting me.
Well, this has been a long time in the making with our calendars and being on different continents. It's taken a little bit, but I'm so glad to have you here today. So what we're going to discuss is prostate cancer and kind of the state of things, if you will, where we are in 2022. And one of the things that I found in all of my research and in all of my kind of Sherlock Holmes detective work was that people around the globe have different ways that they screen for prostate cancer, and there's different groups that are infected or diagnosed rather with prostate cancer at a higher level. So when I was looking at all of this research, I noticed that men that are African descent from the Caribbean and here where I am in North America are the largest group of men in the world that are diagnosed with prostate cancer. So what I wanted to do is I wanted to try and get to the bottom of that. And as I said, we're not going to try and solve world peace in this short episode, yeah. But I don't want to say it fascinated me because it actually keeps me up at night wondering why. It's just how my brain works. So I started looking at things. So I said, well, okay, if it's men of African descent in the Caribbean and in North America, what about the state of prostate cancer in Africa? And so that's what I wanted to talk to you about. And I know you deal in multiple levels of cancer treatment. But what I noticed in the research, and I'd like to get your opinion on this, is that although North America, the continent of Australia, and the continent of Europe have higher numbers, the mortality rate in Africa as a continent is off the chart. And to me, that's troubling. So I wanted to see if you had the same kind of mindset as myself, that when COVID-19 really, came on the scene in 2020 and just impacted everyone globally, certain countries, and then even in North America, different provinces and different states, for instance, in America, had lower testing and some had higher testing. Yeah. And so the ones with higher testing, obviously the numbers were off the chart. But then the ones that did lower testing for COVID-19 had a higher mortality rate. So I started trying to put the pieces together and say, well, maybe that is, what the issue is in the high mortality rate in the continent of Africa. So I just wanted to get your 2 cents on that. So everyone listening and viewing here on YouTube can have a better understanding of, where we are and how we move forward.
Okay, sure. Thank you so much again, RJ. Yeah. So I think your observations and concerns are very valid, with regards to prostate cancer and men of African descent. And it is a challenge that we're facing on a daily basis. So in terms of the answers, I would say that is still research question that we haven't quite answered. And unfortunately, a lot of the information that is out there has not been in terms of the genetics behind prostate cancer. We don't have much information on African men. African American, yes, there is some information, but in terms of research in Africa, we are still a long way. Research is one of those areas that we are lagging behind in. Why? Because we're still just on the treatment side of things. There's a shortage of health professionals. So we're all sort of stuck in our clinics and we're treating patients. By the end of the day, we are tired, and to think of a research question and, trying to...
I know, and get invited on podcasts in North America, right?
No, this is fun. This I enjoy. It's the highlight of my day.
Oh, perfect.
Yeah, but the research has been an issue. And unfortunately, we do need to do research to answer that question. And also in terms of even treatment, we follow American, European treatment guidelines. And those are done, in a different group of patients, different demographics, racial differences. So we don't have our own guidelines. So we follow those guidelines. So, and it's also different. I mean, when you're talking about the racial differences, how patients react to treatment, how they respond to treatment. So it's always a little bit of a challenge. So that's one side of things that we're hoping, we improve on. And also sometimes it's time, and also the funding is an issue. And the funding. And with the question you're asking has a lot to do with the genetics. So there's certain gene mutations that we carry maybe as Africans that predispose our men to developing prostate cancer. And the prostate cancer is definitely more aggressive than in Caucasian men. I mean, that we can't dispute. You are right that there is definitely that observation. So we need to answer why is, prostate cancer more aggressive in African men? Why does it occur in younger men? We find it, I think I've seen a patient 38 years of age with prostate cancer. And, we tried to diagnose all sorts of other things, and we couldn't, run away from prostate cancer, but it baffled all of us to say, but why? This was stage 4 prostate cancer. And how does a 38-year-old man, develop stage 4 prostate cancer? So these are things that we face in Africa. So to answer those two questions, why it occurs in younger men and why it's more aggressive. Being more aggressive then leads to a higher mortality rate. So that really becomes a challenge. Yeah. So in Africa, in particular, in Zimbabwe, prostate cancer is, when we're looking at women, men combined, is the third most common cancer after cervical cancer, number 1, breast cancer, number 2, and then prostate cancer. So accounting for about 10% of all our cancers, which is quite significant.
That number is way too high, obviously. So what I'm seeing is that with a lot of other cancers, it could be bowel cancer, it could be breast cancer. The emphasis is on screening. But when it comes to men and prostate cancer, it's controversial because the PSA test is not 100%. It's sort of like casting that net, in a big giant ocean. You're going to catch a lot of things in there. So people that have lower scores may have aggressive cancer, but as a whole, it's a blood test. At the end of the day, that's how I probably wouldn't be here if I didn't have my PSA tested at a routine physical with my GP, and I started spiking, and they said let's err on the side of caution, have another test, came back even higher, and then the referral to urology was then made, and biopsy later diagnosed with stage 3 prostate cancer. But if I did not have that screening, even though it's not 100%, I probably wouldn't be here today. I may have been going along, not knowing, that I had an issue. And then when it was diagnosed, it could have been too late. So that's my emphasis. It's on around the world, making sure that we're screening men. And so it sounds like I need to get you funding, researchers, more help. So
we need that.
I don't know what I can do, but
we do need that.
I'll make a few calls for you and see what I can do. So in your area in Zimbabwe, what efforts have you been seeing over the last couple of years, maybe for early screening or just the numbers? Give me a snapshot, and everyone listening and watching here on YouTube, just an idea of what's the state, if you will, of your area, and if you know the direction of the continent as a whole.
Yeah, so the screening has really, been taken up across the world, and Africa, definitely, we're also screening. So just looking at the trend, the numbers for prostate cancer, they have been on the increase in Africa as a whole due to the PSA screening. We do have the blood PSA test that gives us an absolute figure. And we also have the screening test that will just tell low, high, very high. And, so we do have access to those. And if it's low, then we tell the men, those are cheap. I mean, $5 per test.
I know.
And a lot of,
So that comes as part of the funding, right? So we get funding so we can get everyone lined up test. And maybe we can work
the pinprick.
Yes, exactly. Maybe we work with the government and say, pay for a $5 test for everyone between this age, But we are finding younger and younger, as you said. That's the troubling part. It used to be maybe it's 65 in North America. You do that, then maybe 60, and now they're saying 55. But I'm saying, what's wrong with 40? To be perfectly honest with you, it's a blood test. So I know that's controversial. I know I'll get some kickback from a different urologist, but I'm going to save that for season 2. That's going to be my whole discussion for season 2. But in the interim, you and I are, solving world peace in a half an hour here. So.
True.
So if budget was not a problem, which it is everywhere in the world, but if budget was not a problem, what would you implement? Because you're in the trenches, you're seeing, all types of cancer, but specifically prostate cancer in men. What would you like to see implemented if money was no object?
So just to help you have an appreciation of Zimbabwe, and I think it applies to a lot of African countries. So we do have a heterogeneous group of people in terms of our financial means. Most of our patients are poor, but I would say about 20% are patients of financial means. So they're able to pay for their treatments out of pocket. So they pay cash for the screening test and the treatments, or use medical aid. I think in your country, maybe you call it medical insurance, that when you're sick, they will pay for your treatments. So the rest of the patients, are not able to afford screening. They are not able to afford treatment. So it then becomes an issue with our screening guidelines. I generally recommend from 40 years of age for our Black men. So yes, I'm in agreement with you. So we do go out to corporates, we do go out to churches, and we do actually, offer the screening. So these are for patients that can afford. And what we then find is for the poorer patients, in the medical field, we do say that if you're not able to treat a patient or a particular disease, screening for it then becomes unethical. So that then is then a problem for our patients that cannot afford to say, I'm going into this rural community and I'm going with my testing kits and I have 100 men and I do, I find maybe 5 out of the 100 have a high test score. What do I do with those 5 men? I have to counsel them and tell them that your score is high. It means you're at risk of getting this cancer called prostate cancer. And half these men would be like, okay, educate me. What is cancer? What is even the prostate? We don't have the term prostate in Shona. My native language is Shona.
That was going to be my next question, actually. How do you translate that if there isn't a word in the language for it?
Oh, I just describe it as there's this small thing that our medical books say walnut shaped. We don't even know what walnuts are. So I'm like, okay, walnut. They're like, what is a walnut? I'm like, okay. It's just something that looks like this.
So I have more work to do. I have to create some documents that
walnuts
that are more applicable.
And prostate.
Okay, gotcha. Yeah, remove the walnut altogether.
Walnut shaped.
Oh yeah, I know. That's that's embarrassing.
So it's this little organ that just sits beneath your bladder. Your bladder is sitting on top of it, and your urinary system, it passes through that. They're like, okay,
so it's biology. It's biology class. In their backyard or at a church.
Exactly. So the pipe that your urine passes through, that pipe, yes, it passes through this prostate thing. Yeah. So if it has tumors or these lumps that are growing in it, then you're not able to pass urine properly. So they sort of understand. And the next question is like, okay, if it's going to form cancer, that's going to kill me. Why do I even need it? Why did God even put it there? Right.
Exactly. That was going to be my. So what is the pushback? Is it I can say this as a man. Is there any issues with machoism, or on the other hand, I'd just rather not know, and if it's the will of the gods or or anything else, then I'll just live with it.
Yeah. So this is just education, and they appreciate and understand. You explain that this organ is there. It's important for the reproductive system. It's part of the semen. It works to produce, offspring and things like that. And they appreciate. But as you get older, then it develops these lumps that can become cancerous, or just simple, what we call benign prostate hypertrophy, which is not cancerous, but it can also cause problems with urine. And sometimes you need some scrapings so that, it gets smaller and you pass urine better. So they do appreciate and understand. And a lot of the men, especially the older generation, they would already have started having, urinary problems, difficulty passing urine. So the explanation helps them understand better to say, okay, so I spend longer when I go to the toilet because of this little thing that my bladder is sitting on.
Right.
Yeah.
Right. Oh my goodness. You and I have a lot of work to do. I wasn't expecting that, I have to find researchers and funding, and but in all seriousness, by not having the testing and not being able to diagnose at a earlier stage, it must put such a strain on the hospital system to get men that are now stage 4,
advanced.
Coming in, advanced, and just the numbers are staggering. So it seems to me if the focus should be getting assistance to do preventative work. That's basically what I'm hearing, I believe.
Yes, that is so true. And with your funding, it is most welcome. I mean,
who should I make the check out to? If only it was that easy, I wish.
Oh, it was so, yeah, it's so true. I'll just give you an example. Yes, recently we did an outreach for a church, and we had two men that had high PSA, just the prostate screen, that pinprick one. So they had the high ones too, and one is 78, the other one is 80. So we are sort of stuck with them because they now need to go for a full proper PSA blood test, which they would need to pay $30 for. And if they are diagnosed with prostate cancer, they need to see a urologist who needs to do a proper digital rectal examination. And, you know, you're looking at about $100 consultation fee for that. And you need an ultrasound scan guided biopsy. You're looking at $500 to $1,000 for that, you know, because that's the procedure in the hospital, and also the histology or pathology reporting. That's also another fee. And then, you know, after that, the treatments. So you're looking at a good $2,000-3,000 per patient. So then the question was, why did you go out there to screen? You know, were you just doing it just for fun? And that's what I asked. Yeah.
Oh my goodness. Oh, yeah. As if you didn't, you know, have enough on your plate. You know. Oh no, that's just a staggering number, especially, you know, out of pocket for the most, you know, cases. Yes,
out of pocket.
It's just it may as well be 30,000 US. You know. Because 3,000 or 30,000, what difference does it make if it's, you know, it's such a large figure that's out of reach? So in urology, again, you're not a urologist, so this is you know, just a side question for you. What are the biggest or most common, is probably the better phrase to use, procedures? Is it a prostatectomy, or is it some other type of treatment to remove the prostate cancer?
Yeah, so we do open prostatectomies. In Zimbabwe, we don't have the robotic, you know, your fancy prostatectomies.
All right, where's my list? My list is getting longer. Okay.
So we do open prostatectomies, and the TURP, transurethral resection of the prostate, that's usually as diagnostic for men who are having urinary obstructive symptoms. They have that done, but it's not therapeutic. Yeah, it's more like a palliative procedure. And then the bilateral orchidectomy, that's removal of the testicles. Yeah, for men with stage 4 prostate cancer. That's also the other surgeries that we do here. Yeah.
Okay.
How common
sure
are
that's
those
that's a big conversation to have with someone at the church, right? Oh my goodness. Oh, yeah. So in everyone, you know, listening to the podcast and everyone watching, what is the best thing that we as a group, you know, I try to shrink all the continents. I'm going to make it to all 7, by the way. So far in my season 1, I'm at 3. You know, counting with you the continent of Africa. But I'm shrinking the globe, so to speak, and trying to bring awareness everywhere. So other than the things that we mentioned, what is the best thing that you know, we can do as a society, as a global society, to try and protect men and try and get screening at an early age, or a younger age, probably?
So I think it's really strengthening of our health delivery systems, because for me to go out as an individual to screen patients, I'm just an individual. If I'm not part of a system, then I'm found wanting, which is exactly what happened with the 2 men at the outreach. But if we strengthen our health delivery system, that will actually make a big difference. Like in Zimbabwe, we've got quite a strong, referral network. It starts all the way from rural health clinics to provincial health clinics. They feed into the central or city health clinics and hospitals, and then, you know, to the big tertiary hospitals. So if we're able to use that structure all the way from the rural centers to teach them to have posters, to have those testing kits there, that if they find a high score, then they refer to the provincial, the next level, who are then able to do a blood test. And if they find it positive, they're able to send through to the central hospital. At the central hospitals, we have specialists. You're more likely to have a urologist who can then, if we find it early stage 1, stage 2, we can do a prostatectomy, and the man, is good. They will just need their regular PSA tests. So once we do have a clear sort of referral pathway, clearly structured to say, this is how, with clear guidelines, this is how we screen, and this is where you refer patients to, and maybe even subsidize the PSA test so that the patient won't have to pay a lot of money, then, we're able to then reach more men and be more effective. The challenge that I face, I'm a radiation oncologist. So I think in terms of radiation. So there's always that back and forth between us and the urologists. But when you're looking at it, really, early prostate cancer, the urologist is quite key with their prostatectomies. I come in more for the advanced prostate cancer. So I think more in terms of advanced, disease with my radiation, prostate brachytherapy, external beam radiotherapy, hormone, androgen deprivation, hormone therapy. But like you're saying, we are few in terms of radiation oncologists in Zimbabwe. We're less than 20 for a population of close to 15 million, which is really, so we are understaffed. But the urologists are many. I think in a year, maybe 5, 6 qualify. So they are covered around the country, well distributed in terms of the specialist urologists. So surgery would then have to be the mainstay of our treatment. And for it to be the mainstay, then we need to catch the patients early before the cancer spread to the lymph nodes, before it has gone to other parts of the body.
Right, of course. Now, just, I guess, from an observation standpoint, do you see pharmaceutical companies from Europe? Do you see pharmaceutical companies or researchers from North America in Zimbabwe? Are there groups coming to do research to assist someone like yourself or assist a urology team? Is that something that you would see, or is that something that you would consider rare?
Yes, we do have that, especially for cervical cancer. We definitely European, American research groups that we've partnered with. Breast cancer also. For prostate cancer, there hasn't been much research interest, but cervical cancer, the HIV related cancers, there's been a lot of funding for those type of cancers. Yes, definitely. All right. Okay. Wow. And I'm part of a coalition that we call African Cancer Coalition, that was formed by the American Cancer Society with the NCCN, and that's North American. So they helped to bring us together, sub-Saharan Africa. So we've been working on cancer guidelines. So I'm actually part of the prostate cancer guideline working group. So it's actually been quite good. And the mandate for that African Cancer Coalition with the American Cancer Society was to help us come up with guidelines, one. And then once we've done that, hopefully we're hoping as a group of sub-Saharan countries, we can actually source for drugs as a group. And that way, because of our numbers, we can sort of lower the pricing. So those are the things we've been working on. So research is one of the things that we've been looking into as the African Cancer Coalition. So prostate cancer research definitely is something that would be, most welcome.
Okay. Well, hopefully I can make it. I'm not sure when, but I'm definitely going to try to make it to Zimbabwe and, see everything for myself firsthand. And,
Awesome, awesome.
I'll give you a heads up that I'm in the neighborhood, so to speak.
You are most welcome.
Well, listen, I thank you so much for your time today. I know it's at the end of a busy day for you, so I really appreciate it, and thank you so much for sharing all this information. It's so valuable, and it sounds like we have a lot of work to get accomplished here. So I'm going to have to get busy and see what I can do.
Oh, you're most welcome. And thank you also for inviting me. I totally enjoyed talking about cancer, trying to see how best we can improve cancer in Zimbabwe, the outcome of our patients. I appreciate this. Thank you so much.
Well, listen, thank you so much and have a great day.
You too. Thanks. Bye-bye.
Well, that's going to do it for us today. Be sure and check out the free resource section at 𝐥𝐤𝐤𝐵.com. And remember, a journey is something you do on your own, but an adventure is done with loved ones and friends. Until next time, I'm your host, R.J. Windham.
Thanks for joining the Patient to Patient podcast. If you enjoyed this episode, make sure to like and subscribe for free. If you know of someone that could benefit from today's show, make sure to share this episode with them.